everybody to please don't stand by and mute.
Hello, I'm Dr. Parimal. Can you hear me?
Yes, sir.
Good evening. How are you?
Yes, sir. Good evening, sir.
Should we start?
Say one minute, please.
Welcome, Dr. Desai, sir. Good evening, sir.
Good evening. How are you all?
We are fine, sir. Dr. Priyamada at this end.
Yeah.
Thanks
Nice.
a lot for coming, sir. Shall we start?
Yeah, we should start. It is 8 o'clock.
Yes.
Yes. Good evening, everyone. Indian Medical Association Gwalior cordially invites you for a very informative webinar on the prevention of diabetes blindness, Close the Gap. I am Dr. Anupriti. I am working here as a uvea and a retina consultant in Ratan Jyoti Netralaya Gwalior. We welcome all the faculties, speakers, discussions, and all our guests who have spared their time for the interesting webinar. First of all, I request Dr. Priyamada Bhasin to give a short note just for the introduction. She is the President, IMA Gwalior. Thank you, Dr. Anupriti. Good evening, everyone. Respected Dr. Parimal Desai, sir, Chairman, IMA PDB. Respected Dr. Anil Bhatia, sir, State President, MP. Dr. Marathe, sir, Convener, IMA PDB. Respected Dr. Raju, sir, I don't think that he has joined right now. He is advisor to IMA PDB. Respected Dr. Subidhi, sir, National Coordinator for IMA PDB project. Dr. Rajiv Raman, he is Senior VIA Consultant, Shankar Netralaya. Dr. Dhananjay Shukla, he is Director of Vitro Retina, Ratan Jyoti Netralaya Gwalior. Dr. Gajen Chawla, Senior Retina Consultant, Bhopal and Secretary, MP State Ophthalmological Society. Dr. Navneet Agarwal, he is Senior Physician and Diabetologist in Gwalior and he is Secretary IMA CGP Gwalior. I welcome all the officials and members of different branches of the IMA, ophthalmologists and other doctors joining from different parts of the India. I find today's topic for the CME is very important in the present scenario because diabetes mellitus has emerged as an important public health problem and diabetic retinopathy is an important cause of the blindness. But this blindness due to diabetes is avoidable in approximately 98% of the cases if detected and managed early. We need to close the gaps between the patients and the management by identifying the barriers like lack of awareness regarding the diabetic retinopathy, not only in the community and patients, but amongst the doctors too. There are financial constraints regarding and distances, lack of trained staff and infrastructure. They are the major barriers. It is very alarming that only 1/3 of the patients referred for the management of diabetic retinopathy reach ophthalmologists. We need to fill the gaps by active collaboration between primary care provider, that is clinician or diabetologist, and ophthalmologist. That is why this kind of the meetings are essential in order to reduce the blindness burden by combined and holistic approach by all. I request Dr. Anupriti to start the session and I request first Dr. Desai, sir, to please address the session. Thank you.
Good evening, all. It is my great pleasure, Dr. Prakash. I think Dr. Anil Bhatia ji, Dr. Prakash Marathe, Dr. Priyamada Ben, Dr. Anupriti, and the esteemed speakers. It's my great pleasure to be on this webinar on my favorite subject. It was my subject when I appeared for my MS. In our time, it was a 3 hours, one single essay that was diabetic retinopathy. And that was one of my favorite thing. And I definitely think that you have taken, or you have just struck the right chord, because it is one of the major causes of blindness in our country because of the lack of knowledge towards treatment of diabetic retinopathy amongst the patients and among the healthcare persons apart from ophthalmologists. Plus, this, as Dr. Priyambada told, that it is a very expensive procedure. So, and in majority of the centers, except for major cities, the treatment of a very advanced diabetic retinopathy is very primitive. So it is good that to start with, as a chairperson of this session, as well as of prevention of diabetic retinopathy, IMA, I would definitely, I'm so happy to address the August gathering, and I would not take much of the time because uh, means it is very important to listen to the esteemed speakers. So thank you for patient listening. Please go on.
Thank you so much, sir. I request Dr. Anil Bhatia, sir, to please address the meeting. He is State President, IMA, MP Chapter.
So you're muted, sir. You're muted.
Sorry.
Thank you, Dr. Anupriti and Dr. Priyamba Vadda,
Sir, one
Vasu
second.
Madam. And at the same time, I congratulate the whole team of IMA headquarter and our IMA Gwalior for organizing this prevention of diabetic blindness, close the gaps webinar. And at the same time, I'm requesting Dr. Parimal Desai, who is the chairperson of the IMA headquarter, prevention of the diabetic blindness, and all the speakers, Dr. Prakash Marathe, Dr. Gajendra Chawla, Dr. Subuddhi, Dr. Navneet Agrawal, Dr. Rajiv Raman, Dr. Dhananjay Shukla, and lot many friends. Dr. Sasmita Mungi, she is the director of the IMA CGP MP State, and Dr. Lohia sir, who is the associate director of the CGP Gwalior. I congratulate all of you for arranging such a nice program for the updating of the prevention of the diabetic retinopathy and the blindness. So I can understand that there are so many speakers about the subject, but still to be very precise about the blindness prevention, I can just such a regular eye examination of the diabetic examinations of the person who is suffering from diabetes, and if he has developed retinopathy, lot many treatments like injection, laser, and other things are there. May need some fluorescent angiogram examinations also, and especially for the proliferative diabetic retinopathy, we should have some lesser and good treatments also all around. And I'm sure through this webinar, lot many doctors will be benefited, and at the large, the public at the large will be benefited out of it. Thank you so much, and I wish you all the best for this program. And I'm very sorry because I have a very strict working committee meeting day after tomorrow morning, so I may not be able to continue with the meeting. And thanking you all, and thank you so much for inviting me for this program, and wish you all the best. Thank you so much.
Thank you, sir. Thank you, sir. Sir has a very glorious history in the IMA journey. He is a member of IMA for last so many years, since for 38 years, and he has been on various posts in local, state, and national IMA. And at the present, he is our president in the MP state, and he has received many prestigious awards from the IMA. Really, sir, thanks a lot for being with us. Thank you, sir, once again. Thank you.
Thank you. Thank you so much. Thank you. My best wishes, sir. Parimal, sir, thank you so much, sir.
Nice.
Thank
Dr.
Thank you. very much.
Prakash Marathe, sir, thank you so much, sir. And all
Thank,
the
thank you,
dignitaries
sir. Thank you so
who are
much.
here for the program. Thank you so much, sir. But I'm sorry I have to leave because I have to make some arrangements for my state working committee tomorrow.
Thank you so much.
sir.
Now I request Dr. Prakash Marathe sir to please address. He is a senior vice president IMA Maharashtra zone, Maharashtra state. He is also the convener of National IMA headquarter Delhi Standing Committee for the Prevention of Diabetic Retinopathy Blindness. Welcome to the meeting, sir, Dr. Prakash Marathe.
Hello. Good evening, all. Am I audible?
Yes,
Yes,
sir.
sir. You're audible.
So, good evening, everyone. Respected President of IMA MP Chapter, Dr. Anil Bhatia ji. Then the Chairperson of Standing Committee of Prevention of Diabetic Retinopathy Blindness, Dr. Parimal Desai sir. Dr. Priyamada Bhasin, who is the President of Gwalior Chapter. All the esteemed speakers, my friend Dr. BNR Subudhi, then Dr. Raju Raman and everyone. Then the dignitaries of IMA MP Chapter, our office bearers, then CGP wing especially, that is College of General Practitioners, were responsible for organizing this particular CME. I must congratulate IMA MP Chapter and basically Dr. Priyamada Bhasin, who is the state coordinator for IMA PDV, for organizing such a wonderful program. I think this is the need of the hour. What Indian Medical Association at headquarters had thought while defining and formulating various standing committees. One of the important committees is prevention of diabetic retinopathy blindness. It has been working since years. And basically, this is the committee which is in relation to the vision problem. Hence, ophthalmologists are involved. Not to forget the important role of All India Ophthalmological Society, which is the organization of all ophthalmologists across India. And the basic or mother organization, that is Indian Medical Association. Both of them have been working and joining hand in hand since years together. What I remember, under the leadership of our past chairman and now advisor, Dr. NSD Raju. Along with that, Dr. BNR Subodhi, Dr. Nirmal Frederick, Dr. Soumya, and so many people have been working very sincerely since years together. Recently, in the past year, we have launched so many state chapters. And one of the vibrant chapter is MP chapter. And basically, while formulating these state chapters, we had thought of appointing state coordinators for various states so that they start functioning in their states in a better way, to have some CMAs, then some screening scams, then awareness programs. And I am very happy to see that MP chapter has been working on these issues. And when I see this particular cause of prevention of blindness, I think all the physicians, family physicians, consultant physicians, then general practitioners, they have to be very careful while checking diabetic patients. Most of the times when the diabetics are being checked by these people, and when the diabetes is under control and patient feels that vision is really very good, even the clinician feels that vision is really good, why to send these patients to ophthalmologist? And the take-home message for today's program should be that family physicians, and general practitioners must refer their diabetic patients to ophthalmologist, not to ophthalmologist, but then vitreoretinal specialist. And if it's not possible for them, at least they should screen these patients in their clinics, their hospitals, send those images to health centers. Basically, it is an important role of teleophthalmology nowadays. By this particular means, I think the diagnosis of early diabetic retinopathy can be done. And if it is done at proper time, proper place, and the proper preventive treatment is given to the patient, the vision is saved. And that is the main motto of our standing committee. Basically, there are various standing committees at headquarter level. Most of them are working on social cause. But this is very important committee because it is directly related to the vision of the patients. India is a very big country. It is very difficult to cover all the country in one go. And basically, state chapters are very important. So people like Priyamada Bhasin and all the team of Gwalior as well as MP, when they are looking forward for such a cause, and what app name they have given for today's CME, that is Close the Gaps. Perfect name. And I think we have been working hard in this direction. I'm not going to take much more of your time. Under the leadership of our chairman, Dr. Parimal Desai, We have been thinking of having such programs in each and every state, maybe in physical format nowadays, because the COVID era probably has been under control and we have been working physically. And if not possible, webinars is the new thing what COVID era has given to us. I'm sitting here in Australia at present. It's quite late midnight, but because of invitation of Dr. Basin, I thought I must join from Australia. Nice to see all these faces in India, and best wishes to the committee, best wishes for the webinar. And I hope by this particular webinar, we'll be saving many more eyes in our country. Thank you so much. Best wishes for the webinar.
Thank you, sir. Thank you for joining from the Australia, sir. Thanks a lot, sir. Thanks for honoring our invitation.
Thank you. Thank you.
Thank you so much, sir. Now we should start with the main session, the speakers. I would like to request Dr. Gajendra Chawla, sir. He is a leading ophthalmologist in Bhopal, and he has a very vast experience of more than 25 years in the service. I request Dr. Gajendra Chawla, sir, to please give the talk on close the gaps, aims and objectives. That is the most important talk, because that is the most bridging importance which has to be closed first. Then only we can treat the patients. So we welcome you, sir.
Thank you.
Dr.
Thank you, ma'am.
Gajendra. Yeah.
Thank you, ma'am, for kind invitation and introduction. So I'll start my talk. Thank you for grateful thank to IMA Gwalior and PDB group and all other teams who has organized this wonderful webinar. So prevention of diabetic blindness, close the gaps, aims and objective is my topic has been given. As you know, due to the change in the lifestyle, food habits and hereditary reasons, number of diabetic patients are increasing. And so the patient with diabetic retinopathy and maculopathy, including the vision threatening diabetic retinopathy, they are also in rise. If you look into the statistics, the approximately 70 to 75 million diabetics are reported in India. They are estimated, and it is predicted that by 2030, this population will be more than they will cross the 100 million mark. The diabetic retinopathy is one of the leading cause of the blindness in the working age group, and almost 20 to 25% of diabetic patients will have some form of diabetic retinopathy, and the severe vision loss is seen in almost 7 to 8% of the population. Diabetic retinopathy, we are seeing the vision loss, but apart from the vision loss, there are so many factors which are affecting the patient life. So the quality of life is also compromised. They are associated, they are having a severe debilitating effects, like there is a loss of independence if there is a advanced vision loss, or they are having a restricted mobility because of poor vision. Sometimes they are finding difficulty in the
Do you have any slides? Sir, we are not seeing your slides. Do you have any slides?
No, it's not moving.
No, sir, we are not seeing your slides actually.
Sorry. I'll just again share my screen, de-share, and then
Yeah. Please.
go back. I was thinking I shared the screen. Now we are seeing my slides.
Yes, now we can see the slides.
So should I start from?
You can continue.
Continue from here. Okay. So almost 20 to 25% of diabetic patients will have 20 to 25% of diabetic patients will have some form of DR, and the severe vision loss is seen in almost 7 to 8%. Because of the diabetic retinopathy, we are having the vision loss, but that is reflecting us, and that is our quality of life is also compromised because of this poor vision. And there are we are having a loss of, the patient may have a loss of independency or mobility. They are having a difficulty in self-care activities, and because of all poor vision, they are having they are isolated socially. There are psychosocial impact also has been reported with poor vision. They are having a poor social life. They cannot do their hobbies. They cannot, because they have loss of independency, or they are difficulty in mobility. They cannot maintain the personal relationship, and that's the reason they also have a poor social family social network, and they cannot perform they cannot take a leading role in the community positions. There are also adverse emotional effect. They are having a fear, they are having anxiety, they are having a loss of confidence, they are having a stressful life, and so on. And all these lead to a impaired mental health, and that lead to their depressions. The financial impact is also there with because of the diabetic retinopathy, because of the loss of work productivity, there is less income, but then treatment is required. It is very costly treatment, which Dr. Dhananjay Shukla is going to talk about, and they are having an increased expenditure. It is only not the eye which is having the costly treatment. These patients normally they are having a lot of comorbidity, and that increases their expenditure more. So quality of life decreases as the duration and severity of diabetic increases. But the question comes, can we prevent or reduce this vision loss and improve the quality of patient in these patients? Answer is yes. Single answer is yes. Single annual eye examination of all diabetics is the key. And if you do the screening regularly, we can detect this diabetic retinopathy problem early, and we can give a prompt and effective treatment, and we can reduce the risk of irreversible vision loss by 90% or even more if we detect properly. Dr. Rajiv Raman is going to talk about this screening program and all these things. In India, the annual screening rate is around 30% at present, because of the gap between patient, primary care physician, and retina eye specialist. But how we can close this gap? As Dr. Priyendra in the introduction, Dr. Bhasin has already said, the role of endocrinologist or primary care physician is the most important, because the patient, the diabetic patient, always visit to the primary care physician or diabetologist at least 3 to 4 times in a year, but they don't come to the eye specialist. They report to eye specialist when there is a problem in the eye or they are having a poor vision. So if we do an annual eye checkup, probably we can pick up these patients, we can pick up diabetic retinopathy in early stage. So it is not that our physician friends, they don't advise. They advise, but they don't insist. Some of them don't insist. So my request to my primary physician is they must insist for annual eye examination. Means once they are asking for a patient to come with the report, they should ask, and they should insist he come with the report of eye specialist for and they should do an annual eye examination. Cross referral is a very important thing, because sometimes when patient we see in our OPD, patient is coming to us with the loss of vision or poor vision, and they are not aware of, at least in India, because we don't have facilities, or we don't have a system of annual regular investigation or regular checkup, general checkup. There is we are lacking in this system. So patient comes to us in our clinic with the poor vision, and then we diagnose them there. If they might be having a diabetic retinopathy, there we should ask for the investigation and send to primary physician for their checkup. And similarly, the physician should also cross refer for a eye examination. Awareness training of medical and paramedical personnel, especially in rural India, is very important part, which probably we have to work. And this seminar is one of the that type of thing which we are underway. So awareness and training of medical and paramedical personnel, especially in rural India, because in urban areas, yes, we are having some awareness. We are talking about, we are having CMEs and everything, but probably thanks to this COVID, at least one thing is now we are having a webinar type of system in last 2 years. We can connect with the rural India in rural India our personnel, our friends, and we can train and we can create awareness amongst them. We should have an outreach program of diabetic retinopathy screening. It is a very important thing which I should insist. And last 13-14 years I am working on this, thanks to my mentor Dr. Badrinath and Dr. Rajiv Raman, when we started this our diabetic retinopathy project in 2008. And for that we are working still, and we are from our hospital, our team is going and we are organizing about 15 to 20 or even more camps in the rural area. All CSC level we are organizing the surround Bhopal. We are covering almost 120 kilometers, and we are doing a regular camps. And nowadays, social media is very important tool with us. We can use WhatsApp, YouTube, Instagram, and so many things are there where we can create the awareness program. I remember last month we are having probably Dr. Subodhi has done some 1 minute videos from 1 month. We are having the diabetic retinopathy awareness programs has been done. Mobile Apple app will be available soon. Dr. Rajiv will be definitely going to cover on this aspect. That if available, probably will reach to the remote areas very soon for this diabetic retinopathy screening. If once you diagnose, the prompt treatment by a retina specialist, very early diagnosis and prompt treatment in the form of laser, intravitreal injection, operation by retina specialist will definitely help in the preventing and reducing the vision loss. And there are certain challenges which Dr. Dhananjay Shukla will cover in his talk. So diabetes-related blindness can be prevented, reduced by the combined efforts of primary care physician, endocrinologist, and eye retina specialist. Strict control of diabetes and annual eye examination is the most crucial. Early diagnosis and prompt treatment is the key. If you look into the picture, the early stage of diabetic retinopathy, with background diabetic retinopathy, it is the PCP, primary care physician or endocrinologist has to intervene for a good control, strict control of diabetes. Once it is in a pre-proliferative stage, and then if it goes to the advanced stage, probably the role of retina specialist comes into the picture. Thank you. Thank you so much for patient sharing and giving the opportunity to speak on the topic. Thank you so much.
Thank you, sir. Thank you for a very nice talk. Now I request Dr. B. Nageshwar Rao Subudhi, sir, to please give his talk. He has served as a head of department in MKCG Medical College, Behrampur. He is also a national coordinator for National Committee for the Prevention of Diabetic Blindness Project. He is also a social activist with a vast academic experience. He has established Ruby Eye Hospital for the benefit of the people of Odisha. We welcome you, sir. Thank you so much for accepting our invitation for the talk.
Unmute. Subodhi, unmute yourself, Dr. Subodhi.
Yeah, yes, sir. We cannot hear you, sir.
Can you see my slides?
Yes, we can see your slides, sir.
It's not moving. I'm sorry. I think I will go like this only because the other one is not working. Let me go like this because the other one is not
okay.
Working.
Yes,
I think it's visible. So
yes.
thank you. Thank you very much. First of all, I must thank Dr. Priyambada inviting me to speak on this topic, mechanism of morbidity in the prevention of diabetic blindness. So I respected Dr. Parimal Desai, chairperson, IMA PDB, my friend Dr. Prakash, and all the office bearers of IMA MP, IMA Gwalior, and of course my chairman, past chairman, Dr. NSD Raju. I thank you all for this nice program conducted by Dr. Priyambada Vasin. So I was waiting for the last 3 months because the last program we had is the launching of Punjab program. After that, it was completely stopped. So the only day before yesterday, Dr. Priyamada called me, said that we will be conducting the program. Really, I welcomed her. And within 2 days, she prepared the whole programs. Thank you, ma'am, doing that. So I have been associated with IMA PDB Standing Committee from 2015 to 2022. Well, this year only, March only, the new new standing committee constituted, from which I've been rested. So as a member of the committee, national coordinator and secretary, I worked for the last 7 years, and we have launched almost this project in 20 states. And I'm in the instrumental to select state coordinators from different states, so that I thought that the project will continue in the different states at the state level. And that's the fruits we are seeing today by Dr. Priyamada Yasin, who is the state coordinator for the MP. So these are my activities. In the last 7 years, we moved from east to west, north to south, including all the eastern states. Even we have visited Khardungla Pass. If you can remember, see the Khardungla Pass, we have conducted a program there also 2 years back. So it was a really wonderful association with this standing committee, and I've been working. And even off the committee also, I'm working at the chair, secretary of the Teleoption Society of India. So today's my topic is mechanism of diabetic blindness. So as you know, diabetes is a major public health problem in India, and diabetic retinopathy is an important cause of avoidable blindness. Up to 98% of DR-related visual impairment can be avoided by early screening and prompt management. I should add, awareness also is essential for that. According to the WHO, India had 69.2 million people living with diabetes in 2015. And 2020, it is 77 million. And with the last 2 years, it has become surpassed 80 million. And we expect by 2030, more than 98 million diabetic people in India. A huge population, diabetic population in India. If you see the SARC region, the southeast region is characterized with a high level of diabetes, prevalence of type 2 diabetes, despite having a young population with relatively lower rates of obesity than that observed in the high-income developed countries. Probably this has been postulated to be the result of South Asian phenotype with a higher waist circumference than in other countries, which has implications for diabetic retinopathy. And the risk for DR is almost twice in young compared to the developing countries. Assuming that the sight-threatening DR affects about 10% of people, take 10% population. Now we say that 20% live with diabetes. The number of people with STTR would increase to a greater level. It's a really great burden to all of us. So how to reduce that? Effective awareness and screening programs embedded in the existing health system at all levels, coupled with treatment facilities nearby, and you should find an economic treatment too. Also, should be emphasized over the next 2 years or next 2 decades, I would say. So prevalence of DR is increasing at an alarming rate. With the last 2 years, it has increased by 3 million, almost crossing 80 million. And the number is more so by the post-COVID era. Because during COVID time, a lot of people have taken steroids, and a lot of people have been not screened. A lot of people could not find time to visit a doctor because of the corona shutdowns. So all these things, they increase the diabetics in our country. Already I told this. So if you see the statistics by so many studies, whether it's a Beaver Dam study, whether Blue Mountain study, whether Visual Impairment Project, any study, if you see that any retinopathy is a 20 to 40% of diabetic retinopathy. In India, similarly too. If you go whether the CURE study, whether our Armin study, or it's a Sankaratra study, all the studies, they say that approximately 80 to 20% have diabetic retinopathy in India. But the most important fact is that what we see the tip of the iceberg. You see one study, that's a CURE study, diagnosed DM is 6.1% and undiagnosed DM is 9.1%. Because there are a lot of undiagnosed diabetes are amongst us in the Indian population. We have to catch them. That is the gap, I would say that is the gap by the physician and ophthalmologists. So you find out every year 12% increase in the diabetic population in India. So diabetic retinopathy is a major global health problem. There's exponential increase in the diabetic population from 100 million in 1980 to 422 million in 2017. It is more than 426 million at present. And as everybody said that 20% of these people have the diabetic retinopathy, and 5% are likely to become blind for the vision-threatening retinopathy, which is the leading cause of preventable blindness. So what are the issues? Diabetic retinopathy, because the quality of vision is more than the quantity to vision loss, and the vision impairment is more than the blindness. Blindness or vision impairment in the working age group, because the most of the diabetics are now younger age group, around 50. So they are the earning member of the society, earning member of the family. So you can see there is a large economic loss to the society, family, and the country. But this can be avoidable by our efforts. And diabetic macular edema, you must have seen that the common cause of loss of vision diabetes is the diabetic macular edema. This slowly, asymptomatically leads to the vision loss, and the patient comes to us at a later stage. So how to prevent this? The global issues are geographic location and features, healthcare infrastructure of that locality or the country, and national economy and resources. So all these things can be added for the prevention of diabetic blindness. But the most important being the awareness about diabetes and diabetic blindness. Indian scenario, nothing less compared to all other states or all other countries. 80 million diabetes in India, 16 million will have diabetic retinopathy, and 1.6 million will have diabetic blindness. We have to check this. So we can consider that every diabetic patient is a potential candidate for the loss of vision due to diabetic retinopathy at any point of the time. So appropriate and timely treatment can reduce the risk by more than 90%. If you see, if a DM, diabetes, type 1 diabetes, after the 20 years, everybody will have diabetic retinopathy. And of course, in type 2 diabetes, 60 to 70% will have diabetic retinopathy at the end of 20 years. But now diabetes is affecting the younger age group. So that means the patient lives more than 20 years. So by 30 years, almost all the young diabetes will have diabetic retinopathy. You can see everybody knows, but I would like to emphasize that these two states, a mild state, a moderate state, these are missing. These people, they do not come to us in early stage. When they develop this severe NPDR, a very severe NPDR, they run to us at that time. Sometimes they may end in this type of this retinal hemorrhage or vitreous hemorrhage, but nothing can be done, and the vision loss is evident. So these are the two key treatments factors: retinal photocoagulation and the injections, which must make economically available to almost all the diabetics, irrespective of their financial status. We have to see. The IMA PDB Standing Committee has to see this. Let's develop them. Recently, Dr. Praveen Vasist and et al. From AIMS have done a study. It's a National Diabetes and Diabetic Retinopathy Survey, India 2015 to 2019. It's a 4-year RAP study they've done. They've included diabetes and diabetic retinopathy screening around 20 states of our country. They have been included in this randomized RAP study, and they have these key findings. And I don't want to go much in detail in this, but the only thing I would say that there are estimated 72 or 72.96 million cases of diabetes in adult population in India. The prevalence of urban ranges between 10 to 14%, and the prevalence of rural India 3 to 7%. But what we see now, the rural people also are equally affected by the diabetic blindness. So this survey was done using a RAP plus DR survey. And I am fortunate to that I've been associated with the Nayagarh district of Odisha in this RAP study. So all the known diabetes and newly diagnosed diabetes aged 50 years and above were assessed by the diabetic retinopathy by dilated fundus examination with indirect ophthalmoscopy by the ophthalmologist. So these are some of the key features. I don't want to go into details. But all these data, extrapolating all the data for the all eastern zone In the United States, incidence of diabetes is about 9.35%. Incidence of diabetes about 18.95%. And the incidence of vision threatening is 7.5. This is the finding of the RAP study. Reasons: poor awareness, the major cause of diabetes in India. Around 60% of Indians have the poor control of the state sugar level according to the survey. Majority of the diabetes patients never sought an eye checkup. We have to ensure that. 90% diabetes patients never gone for fundus examination. The main reason for the diabetes leading to vision loss is due to the uncontrolled diabetes. That's a very important factor. So my physician friends must note this point. This recently we got a newspaper headlines: number of diabetics among the poor is rising. Awareness is the casualty. The people are not aware. And if you see, HbA1c level of all the cities in our country, there are more than 8. If you can reduce by any means by 1%, the reduction of complications by 31%. So my physician friends, you have got a role to play in our program. The time will come. Once upon a time, China was our elder brother in diabetes, but now the time has come. We will surpass slowly China, and we will be the #1 country in the world. Only thing you have to do, the physicians request which is just either put a mediatic and look into the fundus. If you see any of these pictures, any white dot, red dot, you can see that it is probably a diabetic retinopathy. Please refer the patient to the ophthalmologist. This is my earnest request to my physician friends sitting here. Please pass on this message to your friends. Simple ophthalmoscopy. This is scanning my friend will describe. So I won't take much in describing all these things. You can see the 1935, Dr. Howard Root has predicted ocular complications in diabetes are frequent, distressing, and destined to become one of the challenging problems of the future. And after, you see, almost 100 years, we are seeing that. So what we have to do? Let us join together, TOSI, of which I am the secretary, Tele Association of India. I am a PDB committee, AIOS DR committee, task force committee, government, Association of Community of Ophthalmology India, lot of NGOs like Rotary International, Lions International. All this can, if they join together, probably we can have this, prevent this diabetic blindness. So we can close the gap between the patient, ophthalmologist, and diabetologist. If you can close this gap, you can bring all three together, close to each other. Probably you can achieve our target of preventing diabetic blindness. Thank you very much. I hope in short I could explain everything about that. Thank you very much.
Thank you, sir, for enlightening us. Thank you, sir.
Thank you so much, sir, for a very nice presentation. It summarized many things very point-wise. Without the physician, the gap cannot be fulfilled. So I request Dr. Navneet Agrawal, sir. He is a leading physician and diabetologist from Gwalior. He also holds the post of Secretary CGP of Gwalior and is also among the members of the organizing committee. He will be speaking on the prevention of the diabetic role of the physicians in closing the gaps. We welcome you, sir.
Thank you, ma'am. Thank you. Am I audible? And
Yeah,
my slides are visible, I suppose. Okay. Thank you, ma'am. So thank you, Basim ma'am, for making me a part of this project, like prevention of diabetic blindness. We know that the diabetes is the leading cause of preventable blindness in country, and as we are facing an epidemic of diabetes, so as a physician, as a diabetologist, we all have the responsibility of closing this gap. So basically, as Subhadi sir has said, that there is a huge gap between like referral of the patients from the diabetologist and the physicians to the ophthalmologist. And in country like where we have more than 7 million people with diabetes, and the irony of the story is that more than 57%, more than half of the patients, the people are still undiagnosed, with a huge number of deaths every day. And we have a huge burden on the economic burden as well as in the society. And as Subhadi sir was saying, that people are developing diabetes in the early 30s. So we have a population which is developing diabetes almost a decade earlier, with a higher insulin resistance and a greater insulin secretory defect. So our population which is developing diabetes at the earlier age is bound to get the complications. particularly down the line after 20 years, particularly the retinopathy. And the worst part of our population is that in spite of the best of the treatment, best of the things available, hardly about 20% of people are having a target A1C. So like almost around 4/5 of the people are not yet controlled. So these are the patients, those who are having the higher A1Cs and are bound to get the complications, beat macrovascular complications, beat macrovascular complications of diabetes. And out of that, the retinopathies like we are going to discuss today. So it is the prevalence of the retinopathy has ranged from like 10% to the 15%. And as for the definition of a retinopathy, it is, we know that the diabetes not only is just a metabolic disorder, it is a metabolic cum vascular disorder. And out of that, like there are vascular complications of diabetes of the persistent hyperglycemia. So because of this microangiopathy due to prolonged hyperglycemia, it leads to the appearance of microaneurysm, hemorrhages, exudates, and of the abnormal vessels, which we collectively call as the retinopathy. And as far as the pathogenesis of the retinopathy is concerned, like we know that this persistent hyperglycemia results in the ischemia, results in the like the basement membrane thickening, formation of the advanced glycation end products, oxidative stress, and through the polyol pathway, this is all leading to the retinal hypoxia, which results in the proliferation of the new vascularization, and this ultimately leads to proliferative diabetic retinopathy. And as far as the prevalence of the retinopathy in the country depends on the various studies, the population studied, and it ranges from the 17% to up to 50%, depending on the population, duration of diabetes studied. And as far as the retinopathy, as Sarah has shown that if we see the classification for the physician's point of view, we have two types, non-proliferative and the proliferative retinopathy, wherein the non-proliferative retinopathy, we have early, moderate, and the severe non-proliferative diabetic retinopathy. So for the physician's point of view, for the like the diabetologist point of view, as a general practitioner, we should not wait for the symptoms because we know that it has no symptoms. Patient may not have any symptom, or even the earliest stages of retinopathy, patient has normal vision. And there is a very common perception whenever you ask a patient that go to an ophthalmologist, get your eye checkup, and they say, मैंने अभी परसों ही अपना आँख का चश्मा चेक कराया, मैंने तो अभी वहाँ पे अपना चश्मे का नंबर चेक कराया और मुझे अच्छा दिखता है, and I'm fine with this. So basically, there is a perception that it is just not only the chashma, it is not just only the refraction or the specs. We should be very categorically mentioning the patient that you should get your fundus examination done with an ophthalmologist, because like in the initial phase, there is no symptoms. And as sir was saying that many of the patients, they when come to us or go to the ophthalmologist, they have a good amount of visual loss. And then the chances of reversal and the chances of correcting it are not that good. So the diabetic macular edema may present with the blurring of vision. So like that, at that point of time, patient may have some symptoms. Pre-retinal vitreous hemorrhages present with sudden diminution of vision, and due to lack of symptoms, patients do not consult ophthalmologist at the early stage. So as a physician, as a diabetologist, it's our responsibility that we should be referring our patients of the diabetes on a regular basis to have their fundus examination done. And there are various factors which influence the natural course of the diabetic retinopathy. First and foremost is the hyperglycemia or the glycemic control, then the duration of diabetes, associated comorbidities like the hypertension, dyslipidemia, renal disorder, the renal disease, development of CKD, and the pregnancy, whereas some ocular factors like the posterior vitreous detachment, old chorioretinopathy, and the cataract surgery might be predisposing for this the diabetic retinopathy. And yes, of course, like as we have the role of the genetic factors in the pathogenesis of type 2 diabetes, we have in the development of the chronic complications of the diabetes. This is important. Like when we should ask our patient to get a retinal examination for all type 1 diabetics, there are the recommendation by ADA that all type 1 diabetics, it should be done within 5 years after the diagnosis and every year thereafter. So all type 1 diabetic patients should be going or should be referred to the ophthalmologist for the complete eye examination with every year. And same way for the type 2 diabetics, the retinal examination should be done at the time of diagnosis and then every year or thereafter. So all patients should go for the annual checkup and the complete detailed retinal examination. And if suppose at the initial examination, if patient has any retinal lesion, it warrants more frequent follow-up and it should be on the discretion of ophthalmologist. We all know that the screening test, but for the physicians, we know that the visual acuity, fundoscopy, retinal photography, and there are some like the fundoscopy, it has been revised now from the app-based, from the fundus, and now we have the handheld cameras and even like for the approach to the rural area. So like this has really changed the perception towards the retinopathy screening, and in the era of the AI-based and the machine learning programs, now the images can be transferred to the centers, and where we can then get the initial report and we can advise our patient for the further management and for the final management to the ophthalmologist. And these are some modalities which we know, and as an ophthalmologist, people are using them. And for the physicians, we know that this is a purview of the ophthalmologist. But as a physician point of view, what is our responsibility for preventing this diabetic retinopathy? First and foremost is the glycemic control. We have to bring the A1C in the target, and from the UKPDS data, we know that just 1% reduction in the A1C can reduce the micro and macroscopic complications to a significant amount. Second, after the glycemic control, we should be eyeing for the hypertension control. We should be eyeing for the dyslipidemia or the lipid control. So we should achieve a target LDL, target triglycerides, and definitely we should be advising our patient for the lifestyle management, be it yoga and whatever the physical activity. And on the top of that, we should be advising them to stop smoking. These are some non-retinal ocular manifestations. So like this is from the ophthalmologist perspective. But the bottom line is that most of the time, not often, majority of time, there is a delay in the detection of diabetic retinopathy. There is a delay in the referral of the patient to the ophthalmologist. So there is a lack of awareness in the patient that retina can be affected. They always see that मुझे ठीक दिखता है, मेरा चश्मे का number ठीक है, so I am fine. Because like there are lack of symptoms like the visual disturbance or something like that, but when patient develops symptoms, it is often late. Patient may mistake test for the glasses, like I was saying. Quite often, diabetes and diabetic retinopathy are asymptomatic. Unless indicated by the physician, patient may not undertake or eye checkup. Hence, the importance of counseling for retinal checkup should be done, and we should be advising our patient for the regular checkup. These are some indications at the physician end why we are referring the patient to the ophthalmologist for the annual checkup. If the patient has any degree of macular edema or visual disturbances, any PDR, if we can see in our OPDs, as Subhiti was saying, that we should be doing a fundus examination in our practice, and if we find any earliest marker suggestive of retinopathy, we should be referring a patient to the ophthalmologist. So thank you very much, and I think if we can intervene early, if we can refer early, we can prevent our patients in seeing the blurred images. Thank you very much for the patience hearing.
Thank you so much, sir. Absolutely.
Thank you, Dr. Navneet. Actually, only early referral is not important. Actually, active participation in the management of the diabetic retinopathy patient is very important, because we cannot manage diabetic retinopathy alone as ophthalmologist. We need to have good control of dyslipidemia, anemia, renal status, as well as cardiac status and other factors, BP and glycemic control too. So thanks a lot for briefing us in such a short time. Thanks a lot, Dr. Navneet.
Thank you so much. I request Dr. Rajiv Raman sir to give his talk. His talk will be on diabetic retinopathy in India, beat the epidemic. He is a clinician par excellence with a researcher orientation. He has lots of publications under his cadre. And he is working as a senior consultant with your retina department, Shankar Nitralaya, Chennai. Welcome to sir.
Thank you. Thank you, Anupriti. Thanks, Dr. Basin ma'am, for giving me this opportunity to talk in the IMA. And when Madam invited, it was a great pleasure and honor to be in this meeting. And I think the last talk, Dr. Navneet, I was very much impressed with being a physician, talking so much about retinopathy. Wish all physicians knew what you told today. I think half of the problem of diabetic retinopathy gets solved. So next 10 minutes, I'll be sharing some views how diabetic screening, retinopathy screening we can do, and try to translate these into our clinical practice. So I think this has been enough told, and this is the data from International Diabetes Federation of this year, 2022, where they suggested that in 21, we had 1 in 10 people globally having diabetes, a big number, 537 million people with diabetes. And they projected that in 2030, it will come to 1 in 9. And 2045, it will be 1 in 8. And really, it would be a dreadful condition. The sad part is that half of them, they really don't know that they have diabetes. So I think that doubles the problem to us. And Dr. Subudhi showed this, that these are the top 10 countries with maximum number of people with diabetes in the world. And almost half of the people throughout the world with diabetes just live in 3 countries, China, India, and US. I think we are one of the leaders in diabetes. There's no question. And our diabetologist colleagues also understand that probably our diabetes is a bit different from what is seen in the Western countries. Typically, Dr. V. Mohan describes it as an Asian Indian diabetes phenotype. We don't have, we have people with low body mass index, more visceral fat, more central obesity, more inflammatory markers. We have beta cell response is insufficient, insulin resistance, low rate of type 1 autoimmune diabetes. More and more, we are seeing young onset type 2 diabetes, more rate of childhood obesity, and many of the other things. So there is a different phenotype which has been described, the Asian Indian diabetic. And this was the large study done by ICMR, the in-depth population-based study, which found that there are 77 million people with diabetes today. They also showed that there are rural-urban differences. There are differences as far as socioeconomic status is concerned. And there are certain areas which have very high prevalence, nearly 1 in 10 having diabetes, like Chandigarh, Tamil Nadu, Punjab, and Kerala. And this does show that there are regional variations in prevalence of diabetes. However, though there may be regional variation in diabetes, all states should implement a population-based screening program for diabetes and its complications. Another interesting fact the INDIAB study spoke is about that we are on an epidemiological transition area today. So there are economically developed states and economically less developed states. Rural areas, the things are still stable, more diabetes in higher socioeconomic status. But if you look at urban area, in less economically developed state, we are having low socioeconomic status people having more diabetes. That's something to worry about. And in urban area, still it is more in people who are having a high socioeconomic status. Regarding diabetic retinopathy, this is the data from our population-based study called as SN Dreams, where in urban area, we have 1 in 5 people having diabetic retinopathy more than 40 years. Rural area, it's less, 1 in 10 having diabetic retinopathy. However, the prevalence of sight-threatening retinopathy, that is about 3.2% and 3.8%. And if you translate that, that means today, when I'm talking, we have nearly 4 million people in the country having sight-threatening diabetic retinopathy, DME, PDR, and severe non-proliferative diabetic retinopathy, which need treatment. So that's a big worry. And the prevalence of diabetic retinopathy in newly diagnosed people who never knew that they have diabetes is also high. It's nearly, that again shows that people are not aware about their diabetic status. As an ophthalmologist, it's essential to ensure that we do a timely detection of sight-threatening retinopathy. We have appropriate protocols for a prompt treatment. Education is important, and equally important, like what we spoke, that physician should refer. We should have a referral system for the physician too, because we know that the control of the risk factor are very important even during the management of diabetic retinopathy. Again, this has been spoken that the awareness levels in our country is really bad. And this was one of the KAP knowledge attitude practice. Though people knew something, about half of the people knew about diabetes, very less knew about diabetic retinopathy. And this was another large Queen Elizabeth Diamond Jubilee Trust program, where they did a situational analysis to look at various existing programs for screening. And they did find that 45% of the patients with retinopathy attending the eye hospital already have lost vision. That means we are doing too little, and that too late. So definitely screening is something we need to think about, having a more systematic screening program. So how we identify people with diabetes who are should undergo a retinopathy screening? So all people with known diabetes on treatment or a single record of random blood sugar more than 200, HbA1c more than 6.5, or gestational diabetes when it is first notified to a medical personnel, they all become eligible for a retinopathy screening program. And where to catch them? It can be opportunistic screening when they are visiting an ophthalmologist for a cataract surgery or other surgical procedures. a community screening which is conducted by physicians or ophthalmologists, the non-communicable disease registers which are there in our country. Many of these, many states are maintaining it pretty well. Pharmacy shop when they go for getting the medications, physicians, the most important people whom the first contact of a person with diabetes, or even the labs where they go to get the blood sugar done. So you can try to think of places where you can catch these people with diabetes for a retinopathy screening. What should be the screening interval? So this was our longitudinal study which came out with the incidence and progression of retinopathy. So in India, unlike the Western countries, the 4-year incidence is not high, it's nearly 9%. But if a person already has retinopathy, the incidence of DME and sight-threatening retinopathy is high, it's nearly 11% and 22%. This suggests that those who don't have retinopathy, the need for frequent follow-up is not there. And those who have retinopathy, they need to come more frequently. Now, what classically the American Academy of Ophthalmology suggested that they should have a yearly checkup. However, with a low incidence, that means the chance of developing new retinopathy is pretty low. There's always a question that can we have more than annual follow-up in a patient with a no diabetic retinopathy? And there are nowadays some apps which try predicting the risk of progression, and Retina Risk is one of those apps which try to look at using mathematical modeling, and it has been based on a Wisconsin data. It does predict, and it has been validated across European countries, US, and we also wanted to check whether this will give us some risk that what would be the risk of progression of retinopathy. And we didn't find it's very accurate, and we remodeled it based on the Indian SN Dreams, our data set. We could improve the accuracy to nearly 0.84. That is, just by a systemic risk factors, we can predict to some extent whether this person will develop retinopathy, and it also predicts how frequent a person should come for a follow-up. There are a couple of screening models which are practiced in the country today. So we have community outreach where people do a diabetic retinopathy screening camp using indirect ophthalmoscopy, or a retinal camera opportunistic screening done in diabetic clinic, general physician clinic, pharmacy, medical labs. They can use a retinal camera, or a mobile van approach. Many of the institutes, they are reaching the people to their doorsteps by having a mobile van equipped with a retinal camera to diagnose diabetic retinopathy, or a community based where you can dilate and take in a primary eye care center, the vision centers, or at the PHCs, the screening can be done. Who should take a photograph? So I would encourage all of you to go through the AIOS national guidelines. They have set up some guidelines for diabetic retinopathy screening, and they have given various competence levels, and any person with at least level 1 competency can be involved in the retinal fundus photograph. So he need not be a very qualified person, but he needs some basic skills so that he can acquire good retinal images. Which retinal camera we should use? So again, AIOS recommends that retinopathy screening, any retinal imaging equipment with a minimum resolution of 6 megapixel or 30 pixels per retinal degree is enough to diagnose diabetic retinopathy. Whether to use a handheld versus tabletop. Handheld are also pretty good, but they have got a little learning curve, and initially the images would be more non-gradable. Mobile phone attachment versus standard camera, both are now, you have very high resolution mobile phone. I think Dr. Navneet showed some of those pictures. They are pretty good cameras. However, again, standard cameras, if you compare the resolutions of both, definitely standard camera are better as far as the resolution is concerned. How many fields of retinal image is enough for doing a retinopathy screening? A single 45-degree retinal image, which is centered on the fovea, is enough for screening diabetic retinopathy. However, the more fields you include, the accuracy increases. And now, because we also know that the diabetic retinopathy is not only limited to the posterior pole, or classically what is described as the 7 field, there are lesions beyond that. We are getting a new term called as peripheral diabetic retinopathy. So again, that's important, that 10% of the peripheral DR changes, they suggest a more severe diabetic retinopathy scale. And a third of these, this is the study in Indian eyes, a study done by multiple sites in India. We found that a third of ultrawide field images show what is called as predominantly peripheral lesion distribution. And why it's important? Because it's again shown that those who have these peripheral lesions, they have more chance of progression. They have 4 times more risk of progressing. So it's important to identify these. However, it's difficult to have these cameras as a routine practice for retinopathy screening in our country today, just because of the cost. But however, these would be the ideal ones. We also tried comparing 2 ultra-wide field cameras to see that for diabetic retinopathy screening, do you need more field or you need more resolution? And what we identified that probably more resolution is a better answer as far as retinopathy screening is concerned. Whether you would like to dilate the pupil or use a non-mydriatic mode. So the problem is that one of the reasons why there is ungradable images is because of cataract. Anybody more than 50, and in India, we get cataract a bit earlier age. So if you use a non-mydriatic camera, nearly 30% of the images will be ungradable. More so in people who are aged, where vision is low, again attributing mainly to the cataract. So there are 2 ways, and if you dilate these eyes and then take the image, the ungradability reduces from 30% to 5%. So definitely dilating and taking an image is a good idea. However, you can think of doing targeted mydriasis, like anybody more than 60, I will dilate and take. Or you can even think of staged mydriasis, that you take a non-mydriatic image, and if the image is ungradable, you dilate and then take the image. However, one need to identify these shallow anterior chambers, the narrow angles, because these are the ones which can land in problem, though the chances of having occludable angle or the problem of angle closure is very, very low. I would say 1 in 1,000. But still, that is something you need to keep in mind when you are thinking of dilating and doing a diabetic retinopathy screening. Now, why there is a need for AI for diabetic retinopathy? Again, we have so many diabetics, but we have only 25,000 ophthalmologists. That's the AIOS number. That means every ophthalmologist has to screen nearly 4,000 diabetic per year, which is next to impossible. Another good thing is that it's a time-tested classification system of retinopathy, a very good established globally system, ETDRS, diabetic retinopathy severity scale. And there are a lot of inconsistencies in grading. So these are 30 board certified ophthalmologists, and you have these images, and you can see that there is so much variation among the ophthalmologist itself. What is source of worry? You can see one yellow, where a person has told as non-sight threatening when actually it's a sight threatening retinopathy. It's not good in other diseases. Glaucoma, you can see this is worse. So definitely AI is something which can bridge this gap, and it has been used for retinopathy screening. What do the screening guidelines talk about AI? So in 2020, American Diabetic Association included AI in the care for diabetic retinopathy, and they said that you can use any of the FDA approved algorithms for DR screening. However, they went ahead telling that these results should be documented and transferred to a healthcare professional. They also said that when not to use AI, if a person is already having retinopathy, or if he's on a retinopathy treatment, or he has symptoms of visual impairment, these are the people who should have a in-person evaluation by ophthalmologist. AI should not be used. And what AIOS talks about AIOS, because in India, the problem is we don't have a legal framework to use AI. It's empirical that anybody who has been identified as referable by the algorithm should be seen by ophthalmologist, and a subset, nearly 10% of those who have been identified normals, also these images should be graded by a ophthalmologist. how we can implement AI in our day-to-day practice. So there are two ways. Arvind Eye Institute has been using it as a fully automatic way, where they use it in the physician clinic. Those who have no or poor knowledge on grading retinopathy, you upload the image, the AI gives the diagnosis, and based on that, a referral is done. How we have been using it, Shankar Nethralaya, is mainly for our anterior segment colleagues who have knowledge, but they're not involved in retinopathy care on a routine basis. So they use it as an assistive tool. So ophthalmologist has a chance to grade the images, but then he can cross-check the AI result and augment his grading if needed. There's a short video which shows that how we have integrated it with our electronic medical record. So once the patient comes to the optometrist takes the consent of the patient and uploads the retinal image. And then once they've uploaded, they have a chance to say that whether it is a dilated retinal image or how was the cataract. Now he goes to the ophthalmologist, who is an anterior segment doctor. He has these gradings, so he has a chance to grade the retinopathy level. He sees the images, grades it, and then views the AI results. And if there is a mismatch, he can again look into it, change his diagnosis. So we use it more like an assistive tool in our clinical practice. So just to conclude, there has to be a harmony between the physician and ophthalmologist. It's important for the physician to look into an initial diagnosis and appropriate referral. And from the ophthalmologist's point of view, it's important again to diagnose, manage the diabetic retinopathy stages and refer it for a systemic control. And if this harmony, if this collaboration is well established, that's the way we can give the best care for our diabetic retinopathy patients. Thank you very much.
Thank you, sir. Thanks a lot. Now I request Dr. Dhananjay Shukla, sir, for giving his talk. He'll be talking on the topic of challenges in the management. Sir is an excellent clinician as well as researcher with more than 100 publications under his name. He is working as a director in the Vitreoretina department here in Ratan Jyoti Nethralaya, Gwalior. Welcome, sir. Sir, we cannot hear you.
Am I audible now?
Yeah,
Yes.
you're audible, Dhananjay.
All right. Nice to hear you and see you, Rajiv.
Yes.
And yeah, excellent talk. So you reduced my work a bit. I'm just trying to go to the, give me a second. So is my screen visible now?
Yes.
Yeah, so good evening. Thank you, IMA, especially Dr. Madam Bhasin, for giving me this opportunity. So I don't have much to add, just a little bit, but probably repetition is the mother of knowledge. So let's repeat what the important facts about challenges in the management of diabetic blindness, or what I see in my practice. So let's begin by defining what is blindness. So in the context of diabetic retinopathy by WHO, the blindness is basically vision less than 3/60. Now this, in terms of diabetic blindness, corresponds to severe visual loss, which generally we see in patients due to vitreous hemorrhage or retinal detachment, predominantly a tractional retinal detachment. But we have to be aware that even moderate visual loss, which we define as a doubling of the visual axiom. For example, if your vision is 612, it becomes 624. This is the what the majority of the patients suffer. So you may not think of it as much, just a doubling of the visual angle or reduction of vision from say 612 to 66. So 66 to 612. But remember that it is difficult to recover this vision. It is the visual loss in a working man, generally a younger man who is earning and probably peaking in their careers. So most diabetics are younger than cataract patients. The visual loss is difficult to recover, especially if they are delayed. If you delay a cataract surgery, then they still can get an excellent result. But if you delay the surgery of a diabetic patient, the results goes from say 75 or 80 to nearly 10 or 15. And whatever recovery you get, whether by pharmacotherapy, lasers, or by vitrectomy, needs to be maintained by regular follow-ups. And that's extremely important and taxing for everybody involved. So diabetic blindness is not like cataract blindness, and even a moderate visual loss is significant for a working man. Now let's understand the challenges of the management. The most important challenge, as has been repeated and it requires repeating, is awareness. So most of us are not aware what we are carrying on our back, the burden we are carrying on our back, both the physicians and the patients. Then there are problems of implementation, both by government, by the hospitals and physicians. Then the problem of sustaining a lifelong care and adoption of a lifestyle change. So as has been said by everybody, the most important factor probably is the patient awareness. If we can make the patient awareness, probably a lot of the challenges will just fall away. The most important thing, the patients have to remember that the eye should be checked even when the vision is good. And this has been accented by Dr. Navneet and other physicians as well. And it's extremely important to check the eye when the vision is 6/6. And the diabetes as well as the retinopathy needs to be controlled. It is something we cannot cure like a cataract, and has to be treated and followed up again and again throughout the life of the patient. Some examples from Arvind and Shankar Netralaya, how the diabetic explosion was absorbed by these giants. One, they conducted diabetic screening camps. So I was at Arvind when we started these screening camps. First, they started as screening camps and cataract camps. And later on, they had dedicated diabetic screening camps. And slowly, we saw a massive growth in the outpatient population of our retina OPD. And it was 80% of them were diabetic patients. And that was in spite of the fact that by telem itself, we are actually ruling out most of the patients with mild to moderate retinopathy and just following them up and seeing only the side-threatening retinopathy. As Rajiv has pointed out, and I want to reinforce that Dr. Nam Perumal Swami, our director, was one of the first to give the idea that the pharmacy shops where the patients go to buy the diabetic medicines, they have to be educated to encourage the patients to get their eyes checked. And it was a brilliant, innovative idea. Now about the physician awareness. Navneet said, refer your patients to an ophthalmologist. The problem is most ophthalmologists are not skilled in the assessment of diabetic blindness. Many of them are stuck with direct ophthalmoscopy, as has been shown in some of the previous slides, which proves the point. And they are not aware of either the grading of diabetic retinopathy or macular edema. For example, and if you don't see that actually, if you don't grade this patient or see this patient, there is a patient sitting at the verge of a severe and complete visual loss, but his vision may be 6/6. So most people are unaware that diabetics should have their retina examination done on the day the diabetes is diagnosed. Don't forget about whether it's type 1 or type 2 diabetics. Most of them are type 2 diabetics anyway. So most of the studies say that when the patient, a type 2 patient, is diagnosed as a diabetic, he already has had diabetes for 5 to 10 years. So just refer the patient the first day you diagnose the patient as a diabetic for a detailed retina examination, because he might already be having diabetes for about a decade. Remember that diabetic retinopathy is asymptomatic till advanced stages, as you can clearly see in this picture, where the patient is about to lose vision but is blissfully unaware of that. And the most important reason why we should do that is, even though it looks like a banal job, you see a mild NPDR or moderate NPDR and just ask them to follow up. The patient will think, why the doctor has called me when he just had to follow me up. Remember that nearly all the diabetic blindness is preventable by early diagnosis and management. And these are the words of Frederick Ferris. So this is an extremely important statement in context of diabetic retinopathy prevention. Now, what happens at implementation levels? What are the problems? The India is becoming increasingly corporate, both the hospitals as well as the patient setups, and it works on incentives. So physicians always think, what is there in this for me? So they just advise the patient for an eye checkup, not necessarily for retina checkup, and do not insist on it actually. So again, Arvind and SN had a telemedical solution to this. At least Arvind I knew, he has already told about the AI setting which we did, and I'll show in some detail. So we put a fundus camera there when we were at Arvind in the physician's clinic. The images were teleported to the Arvind Eye Hospital, where a real-time grading was done immediately by a fellow or a student trained in grading of diabetic retinopathy, and given back to the physician in his office immediately. So they needed to refer only the side-threatening retinopathy. This both added the attraction of the physician's clinic to the patient and also incentivize the physician because they could charge the patient for this additional service. So this was one of the setups, early setups, where they used to take a mobile van to a rural setting with a VSET disc like this. A photograph was taken, transmitted to Arvind Eye Hospital, base hospital, where people like us used to grade the diabetic retinopathy or confirm the grading. But this was done only for side-threatening retinopathy. So the AI was used only to detect side-threatening retinopathy, not to grade or recommend treatment. And as Rajiv has pointed, it was always at least a side-threatening retinopathy and or treatable cases, and also all the cases where grading was not possible was seen by the physician themselves. So what are the gaps at the implementation at hospital and government levels? Again, I'll give the example of Arvind, where for the last more than 30 or 40 years, every patient above 40 years has it mandatory to get a urine sugar and BP checked. It's a very simple service, but it has detected many thousands of diabetic patients before they were aware of even their diabetes, let alone diabetic retinopathy. Dr. Navneet here actually suggested in one of our common modules that if you do a free checkup of attendance, you can get maybe another 10% of diabetics within the same setup without trying even harder. That's another great idea. Then again, government has already started training of ophthalmologists in diabetic retinopathy, which is a great initiative. We should also make the retina examination skills mandatory for postgraduates in training, and maybe do not allow them to pass their postgraduate examination before they can do a competent slit lamp biomicroscopy and indirect ophthalmoscopy. As we know that direct ophthalmoscopy is practically useless in assessment of posterior segment. So making retina referrals of diabetics and probably hypertensives mandatory for physician at some stage by the government may be the final straw which we need, like in the case of retinopathy of prematurity, where an expensive legal case against the Regional Institute of Ophthalmology, Chennai, led to a change of physician attitude, especially for referral of ROP for ophthalmic care. And finally, there is a question of maintaining the care lifelong. The patients are reluctant for a lifelong follow-up. It is taxing for the physician and retina specialist to keep advising on regular follow-ups and then keep treating the complications from irregular, unmonitored treatment, sometimes at their own cost when the patient blames their complications because of their fault, with legal and physical attacks on the physicians. We should remember that government is doing their job. They are subsidizing the diabetic treatment, not to mention the recent Ayushman schemes for free retinal surgeries. And as again, some of our diabetologist friends have said, if all the patients with pre-diabetes in the country develop frank diabetes, there's a clear and definite real risk of the government going bankrupt because they are subsidizing all the diabetic medicines as well. So we are all in the same boat and have to work together. Prevention was probably never better than a cure than in the case of diabetic retinopathy. Maybe the government, which is already doing a lot, should think of taxing sugar, simple sugars or sugary foods. For example, the so-called healthy Baba Ramdev biscuits, like they are taxing cigarettes and alcohol. Sugar is known to be as addictive as cocaine, as we see in these pictures, and therefore probably should be expensive, whereas the government is only making it cheaper for everybody. And hospitals, again, I have told a lot of good things about the big hospital, now saying something negative. In Arvind, when I was there, they were encouraging overnight travel for the doctors. And this was encouraged to save time till cardiac events occurred in some of the senior leaders. In all the big institutes and the private hospitals, productivity is measured and rewarded by working hours, taking your work home, working on the weekends, on Sundays. And I personally feel while it also dulls your capacity of work, probably it encourages incompetence and mediocrity. Whereas it also makes the employee health a low priority for the most hospitals. So there's some food for thought, my friends. It is clean food, but probably better for sometimes. The final frontier for preventive medicine is personal, the courage to confront our own biases. It's easier said than done, but let me at least spell it out. It's the sleep, diet, and exercise. Can I feel a lot of us squirming their seats? One hint is that willpower has nothing to do with it. We don't need willpower to sleep well. Can we stop bringing junk food home? Can we stop promoting workaholism at the cost of health in our working setups? Can we stop weekend conferences and post-conferences binges like you see in this picture? So let us walk the talk so that we can dish the advice to the patients which we follow ourselves. Remember, the journey of 1,000 miles begins with a single step. Thank you very much.
Thank you so much, sir. We'll open the panel for the discussion now. I welcome all the discussants, including Dr. N.S.D. Raju, sir. So we have few questions which we received. One question was for Dr. Rajiv Raman. Is the use of the artificial intelligence. So the artificial intelligence is very frequently used in Tamil Nadu and the South Indian states. But its use and its feasibility of using it in the North Indian states, do you have any, can you just give some light on it?
Now people are using it because many of the commercially available cameras now come with an inbuilt AI system. Zeiss has it, Remedio has it, Forus has it. So previously it was a problem because it was only these big institutions who had worked with some of the IT companies we were working. But now it is commercially available. Majority of the retinal cameras which come for screening come with an AI program. And some of them have been published, like Zeiss, we recently published more than about 40,000-50,000 patient data, where so they use what has been developed in Singapore, the Selena. The Seri system is used in the Zeiss camera, which are all commercially available. So I think more and more of these cameras are even used in North now.
And sir, any cheaper options available for artificial intelligence which can be used more frequently?
These are all cheaper. As I was telling, even the Forus camera, simple Forus camera costing about 3 lakhs to 3 to 4 lakhs, which you purchase, comes with the inbuilt AI program. So it comes with a Microsoft program developed by Microsoft. So they are pretty good. So it's not, and even Remedio has their own one, which has been published in JAMA. So it's again not a bad option. So even Indian made, forget about Zeiss, which is a bit costly if you say, but Zeiss camera, again, the screening, the Visual Scout camera is not a very costly device, which comes with the AI, which has been developed by Singapore, free of cost. You don't have to add money to it.
Thank you, sir. So there was one question for Dr. Navneet Agrawal. Sir, do you suggest any particular protocol for the physicians? Like we have already discussed here many a times now, that at least yearly review should be done. But how to make it emphasize to the patient that they should go to the ophthalmologist? Many a times physicians advise the patients to go and visit the ophthalmologist, but patient doesn't turn up to the ophthalmologist. There is something missing between the communication between the physician and the patient and the ophthalmologist. So would you like to suggest something for the physicians so that this gap can be covered up? Is Dr. Navneet Agrawal here in the panel still?
Dr. Navneet, I don't see him.
Yeah, he must have left. No problem.
I think this is the biggest challenge of awareness and making patient know, but really we don't have a true answer. So I would just share the experience. Recently, we completed a study called as Ornet India, which was across 20 cities in the country, where everything was free treatment, everything, like there was no charge to the patient. And you won't believe, nearly 30 to 35% actually of patients who have been diagnosed as sight-threatening retinopathy didn't come for treatment. Now what to do? There is no money involved. It is free. We are giving even the thing to come, and that allowance is also given. Okay. So the problem is people are not conscious about their health. As Dhananjay rightly said, the priorities are different. Their priorities is daily wages, get the money for the day. I think the priority to the health is something which, and we have now engaged a qualitative research organization to work on this people and find out why they didn't come. I think that is something, a big question. So it's not only the awareness. We have to really dig to the cause why people don't come for a checkup.
Rajiv, I have a free suggestion for you. I mean, I can't implement it in my small clinic, but use the service of a psychologist. Actually, I was thinking about that actually, because basically it's a patient bias, you know, or a patient attitude. So seek the service of a psychologist actually, or a population psychologist or transaction analyst, and they can probably help because I don't know.
But what I'm telling, that's so we need to think about that it's not only the awareness of retinopathy. Even patients who have sight-threatening retinopathy, they don't come for treatment. For them, the other things are more important. So I think it needs to be hammered. And I remember still visiting one of the Arvind camps in the initial period, Raj Palyam camp where Dr. Nam was there. He used to say that do a fear counseling. No, sometimes that may work, that if you really instill fear in them, that if you don't get treated within few months, you'll become blind, or few days you'll become blind. I think, I don't know which will work better.
I am also having the similar problem facing, because I am doing a lot of camps in Bhopal and surrounding area. A Sagar place around 100 kilometers, 150 kilometers from Bhopal. Recently in March we did camp, and I have diagnosed about 20-25 patients having some problem which they should come to Bhopal. We are extending discount to them, and our hospital is under panel with this Ayushman Bharat. So diabetic lasers and these things are covered under pre-treatment also. But hardly 2 patients came out of 20 to Bhopal. And those out of 20, 22, I think most of the patients are affordable. They can pay also, but they are not coming. So this problem really is a very significant problem here.
It's everywhere in India, the situation is the same. Whether it's a rural or urban, it's availability of doctors is also very important. Many times the ophthalmists are not available in the rural areas. So they come to the city once, they check the eyes and they go back, and they don't come back again. Again, economy is also another issue, important issue.
I think, may I come in? One of the important aspects is most of the times these facilities are not available at single place. Suppose the availability of a physician checkup and ophthalmologist checkup is at the same premises, probably they may be able to do that in one sitting.
So
and another thing is,
that's right.
Yeah, that's
correct.
And another thing is, whenever it is free, again they are doubting. If it is free, probably it may not be beneficial for them. It may be something experimental to be done on their eyes. And third thing is, in India, even in case of immature cataract and mature cataract, we are observing, unless the vision is totally gone, they are not turning up. So what they feel, okay, I'm seeing little bit, it is not that dire emergency. Why to go? Why to waste our time? Why to take the treatment? I think these are additional points.
Yeah.
Absolutely correct. I think your first point is well taken, because we did recently a study at MV Diabetes and at Shankar Netralaya. So one hospital is a diabetic hospital where you have a ophthalmologist also, and we are the eye hospital. So we looked into same time period diabetic macular edema patients followed for 1 year. How was their compliance? Every month checkups. So diabetic hospital, the compliance nearly 70% came in this 1 year. We had 30%. So you can imagine, that shows the thing, that if you provide this diabetes and diabetic retinopathy care in the same premise, probably the compliance will improve.
True, that's true.
Sir, abhi to problem ye hai ki we have to screen them. That is we are struggling for that. Having a combined setup is again a very big challenge.
And one good news, I think Dr. Gajen Chawla was present. So we had a meeting in Chennai where Dr. Sudha Chandrasekhar, the Ayushman Bharat secretary, was present. And the good news is that she shared that from this year, Ayushman Bharat will give money or insert, like it will reimburse for diabetic retinopathy screening. I think that's a very good move by Government of India. The only problem was they said it will be given only to ophthalmologists. And I was telling that's a problem because physician also it should be given, or I'm not only physician, but anybody who does a screening. And another good thing, they said that it can be given if you have an empanelment. So if a physician has a ophthalmologist empaneled with him, the government can give money. So I think that's a very welcome move by Government of India.
Good move. Yes.
One more aspect in private practice, when the physicians are treating the diabetic patients, or even diabetologists are treating the diabetic patients, they have that fear in that mind. Suppose the patient goes to ophthalmologist, probably they may lose the patient.
Absolutely. Absolutely right. Absolutely right. That's why the referral system is not good.
There was one question for NSD Raju sir. He's there in the panelist right now, or he's not there?
Probably sir has not come.
Okay.
So
Any other questions do we have?
So we are working on the Teleophthalmology Society of India. Dr. Shukla, Dr. Dhananjay Shukla,
Yes.
Rajiv is a member of our TOSI, and we are working on that. We'll see in the coming years how to reach the rural areas with the TOSI incorporate AI. So by little bit trained people, maybe a 10th class pass or a matric fail people, they can be trained to take the photographs in the rural areas where they can be transferred. The image can be transferred to the nearby hospitals or the specialists sitting at a far place. So this is the model we are working. In the coming year, we are working. And recently we had a discussion, probably Rajiv was not there on that day, Kerala model by Mr. Anand Remedio. They've done a model in Kerala where they screen a lot of people for the diabetic retinopathy. And I think this has got a future in aspect.
Yeah, so this was actually after the Ornet India. So in this, we had a public sector, which was Thiruvananthapuram district, where through the project, we gave about 25 cameras to them. And they created a pathway for DR screening in government sector, public sector. And seeing that actually the whole Kerala state has adopted, they purchased nearly 300 cameras now, which they have distributed across all PHCs. And because they have already created this pathway, it was called as a Nayan Mitram project, which we did with Government of Kerala. So now they have now implemented it throughout the state. I think this would be, as usual, Kerala, the first state to implement diabetic retinopathy screening across the state.
Yes. Right.
Thank you.
I've got a question rather for Dr. Raju Raman.
Yes.
May I?
Yes, sir. Please, sir.
In case of artificial intelligence, I think it is a boon and it is definitely helpful for all of us. But in future, is it going to replace the need of VR specialist?
No, it will increase our work because we'll get more of sight-threatening retinopathies. Now we are just seeing the tip of iceberg. We are just seeing a little number of people. Many of them, they are getting blind. They're not going for checkup. More and more people with retinopathy we need to see. And I always see it's better to, rather than screening for retinopathy, if we see those who need treatment, injection, laser surgery, I think that's what, so it is a boon to us.
That's
absolutely.
Thank you everyone for a very informative session. I request Shashmita Mangi madam, so Shashmita Mungi madam, to please give the vote of thanks. Sorry for the confusion of the name, madam.
Good evening. Am I audible to you?
Yes,
yeah, you are audible.
Good evening, respected members of the faculty as well as audience. I am Dr. Shashmita Mungi, State Director, IMA CGP, and also Vice President, IMA Gwalior branch. I feel very proud and privileged to offer vote of thanks in this illustrious gathering. I would like to thank all of you for being here with us and participating in today's webinar. Due to shortage of time, I am conveying my thanks to you all in brief. I seek your forgiveness for the same. I would like to thank Dr. Parimal Desai, Chairman IMA PDB, for his very nice introduction of the topic. Thank you, sir. I would like to thank Dr. Anil Bhatia, President IMA MP State, for being with us in spite of being busy in organizing meeting of State Working Committee, which is on Sunday. Thank you, sir. Dr. Prakash Parathe, sir, who joined all the way from Australia. Thank you so much. I would like to convey my deep sense of gratitude to our eminent speakers, Dr. Gajendra Chawla, Dr. B. Nageshwar Rao Subudhi, Dr. Rajiv Raman, and our very own Dr. Navneet Agrawal and Dr. Dhananjay Shukla from Gwalior. You all have explained about your individual topics in a concise manner, yet the effort put in that was very evident. I am not a physician or ophthalmologist, but all was explained in such a nice manner that it will go a long way in helping us in our clinical practice. We can advise our patients to go for ophthalmic checkup well in time to prevent this crippling complication. Really, it was an academic feast. The panel discussion was par excellence. I wish to thank Dr. N.S.T. Raju sir, former chairman, IMA PDB, and also our own Dr. Purendra Bhasin sir. The discussion was very fruitful. Thank you, sir. I would like to acknowledge the effort put in by both of our beautiful moderators, Dr. Priyamvada Bhasin, who is President IMA Gwalior branch, as well as an ophthalmologist of great repute, and Dr. Anupriti Dhanpal, Uvia and retina consultant, working at Ratan Jyoti Netralaya Gwalior. I thank both of them for their fantastic conduction and moderation. I thank Entod Pharmaceuticals from the core of my heart for sponsoring this fantastic and fruitful webinar. Last but not the least, I wish to thank the organizers of the webinar, IMA Gwalior branch, again Dr. Priyamvada Bhasin, beautiful, smart and visionary President IMA Gwalior, and also the State Coordinator IMA PDB. I also thank Dr. Santosh Singhal and Dr. Rajkumar Srivastav. They are also State Coordinators IMA PDB. My heartfelt thanks to our young and dynamic Secretary, Dr. Prashant Laharia, Smart Assistant Director IMA CGP, Dr. Vidya Lohia, and famous diabetologist from Gwalior, whom you all heard just now, and who is also Secretary CGP, Dr. Navneet Agrawal. I am so grateful to each and every one of you from this August gathering for being with us. I wish you all a very good night. Jai IMA, Jai Hind.
Thank you, everybody. Thank you.
Thank you. Thank you. Thank you, everyone.
Thank you.
Good
Good
night,
night.
everyone.
Bye. Bye.
And
Bye.
I
Good night.
hope
Good night.
we will combat this
Good night.
diabetic blindness under your guidance and support. Thank you. Thank you, everyone.
Thank you.
Thank you.
Bye.
Thank you,
Bye, Rajiv.
everyone.
Thank
Bye,
you, Dr.
Dhananjay.
Bhasin.
Thank
A
you.
really wonderful
Thank
program.
you, sir.
Bye, sir.
Thanks,
Thank you,
thanks,
Dr.
Dr.
Fantastic
Bhasin.
program.
Thank you,
Very
sir.
nice program.
Thank you, sir. Thank you. Good night, sir.
Good night,
Good
everyone.
night.
Good night, everyone.